So then, resistant hypertension is hypertension which is in which the patient has not got to goal despite 3 drugs, which must include a diuretic, inadequate dose, and usually a ACE or an ARB combined with a calcium channel blocker. Also, arbitrarily, patients who are on 4 or more drugs, even if they've got to goal, are considered resistant. So the prevalence is quite substantial, really. It's about 1 in 8 patients that we see in the clinic have resistant hypertension. And it's important because it increases substantially the risk of the kind of things we're trying to prevent when we treat hypertension, which is basically cardiovascular, kidney disease, and cerebrovascular disease. So resistant hypertension requires then some sort of assurance the patient is taking the drugs and exclusion of the white coat effect. Now, how do you think we exclude non-compliance?
We ask them.
What's that?
We ask them.
Yeah, that's not very helpful though, because as you can guess, most people, if you ask them, say they're taking the drugs. So this is a real weakness here. That's why I asked the question. We really mostly don't know whether our patients are taking the drugs or not. If one of them's a beta blocker and the heart rate's 100, you know they're not taking it, all right? But otherwise, you really don't know. And I'll just mention as we go by, there's a recent trial called the Pathway Trial in drug-resistant hypertension, and all the participants had to sign informed consent, which told them at the beginning that part of the trial would be measurements of urinary drug levels to check if they were taking the drug. So even under trial conditions and when the patient is pre-warned they're going to be tested, 40% of those patients were non-compliant with at least one of the medications. In other words, the drug was not present in the urine. So I think one of the things we'll see in the near future is the introduction of urine testing for drugs, because it's a tremendous waste of time and money to go on prescribing more and more drugs, and the blood pressure is not responding. It's not responding because the patient's not taking the drugs. The other thing, by the way, just a clinical suggestion to you is many people don't take the drugs because they feel that they're causing side effects. So always ask the patient if you feel you're getting side effects from your medication, and ask specifically, are the medications interfering with your ability to exercise, to think clearly, to sleep, or to have sexual activity? Because those are the things, particularly the last one, the patient may not want to discuss. They may attribute the drug to poor sexual function, often not really the case, or you could consider giving them Viagra, for example. So how do we define white coat hypertension? Anybody? Perhaps I'll ask you, Amy.
Sure. Is it elevated blood pressure when you're in the doctor's office?
Good. Whereas it is normal
when you're at home or doing
when you're at home. Good. So it's fairly easy to exclude if you can get your patient to bring you charts of home blood pressure. You can also do ambulatory blood pressure monitoring, other things, but that's the easiest. It's important because about 30% of patients diagnosed with having hypertension have white coat hypertension. So does white coat hypertension carry an increased risk of cardiovascular disease compared to no hypertension at all? Can I ask you, what do you think the answer to that is?
Sure. Maybe, although I would imagine it'd be difficult to kind of measure like the true effect of it.
Well, most of the trials have shown no increased risk. It's a little bit controversial. One trial showed increased LVH, but basically trials have not been able to show increased risk. In other words, it's an artifact, all right? And again, it's another thing that you as a doctor have a duty really to diagnose. Otherwise, you're going to be treating a large number of patients for a disease they don't have. And they can only get side effects, they can only incur medical costs as a consequence. Okay. These are the 6 I's. The major causes of drug-resistant hypertension. Inaccurate, and we'll come back to each of them quickly. Inaccurate measurement of blood pressure, and that's mainly the excluding white coat. Inadequate control of salt intake. So could I ask you, what would be your goal salt intake for a patient with high blood pressure?
Less than 2 grams.
Great. So how often would you achieve that?
Me?
Yes.
Probably never.
And me too. So that is probably the correct answer. We don't really have a well-defined goal, but the American Heart Association has always said 2 grams, which is 80 millimoles of sodium. How would you measure salt intake in a patient?
I guess they would just be based on their reporting on from dietary facts.
Again, they lie. It's like alcohol. Do you ever drink? Oh, no, doctor, no. Do you take the drugs? Always, doctor. Yeah. So we know that there's unfortunately where the patient feels that they're transgressing, in this case, eating too much salt, they'll often give you a false estimate. So anybody got a better idea for measuring salt intake?
Check their urine.
Good. 24-hour sodium excretion, because about 95% of the salt we eat comes out in the urine. So providing you're in balance, that means you haven't just started a diuretic or you haven't suddenly changed or suddenly run a marathon, something of that nature. What's in the urine is in the diet. So that's the way to do it. And in practice, a reasonable goal is 120 to 140 millimoles a day. And the average for the United States population is about 170. And there are some communities, like in northern Japan, it's as high as 300, by the way. And since we just raised it, I'll give you a few of these red herrings as we go. There's it's been very controversial as to how important salt intake is in blood pressure, but the recent data suggests that when it's properly measured with salt excretion, there's a continuous relationship between blood pressure and salt and cardiovascular risk and salt. So it is very important to think about salt intake and correct high salt intake, and particularly if the patient has drug-resistant hypertension. Good. So insufficient use of diuretics. Now, which is the most powerful diuretic? Could I ask you for a moment?
Lasix.
Yeah. So which is the best diuretic for lowering blood pressure? Good. Sort of paradoxical, isn't it? And diuretics happens to be my great interest, and one of the things that is hardest to get pharmaceutical companies to understand is that a highly potent diuretic is not necessarily a highly therapeutically effective one. And this is, you two have just exactly given the right explanation there. So, by the way, why do you think thiazides are more effective than Lasix in lowering blood pressure?
They have different effects on sodium levels. I'm not sure really act on that.
Anybody want to come up with an idea?
Where they act on the.
Well, it's where they act in a way, but it's also pharmacokinetics, how long they are and act. Because Lasix was called Lasix, it should really be called furosemide in, scientific circles, because it lasts 6 hours. It actually doesn't. It lasts about 3 hours if you measure it. So it's one of the shortest drugs we have. And the kidney defends salt levels very avidly. So if you take Lasix, you get a large increase in salt and water excretion. 3 hours later, the drug is really gone, and the kidney then retains salt for the following 21 hours of the day. We studied this, and it showed that in a normal subject, there's no net loss of salt at the end of 24 hours after a single dose of Lasix on a high salt diet. Of course, if you have a very, very low salt intake, then there's no way the kidney can retain it, right? Because there's not enough in the diet for it to pull back and restore. So Lasix does work if you really restrict the salt. If you give it 2 or 3 times a day, it's fairly good. But thiazides have a long duration of action. And chlorothiazide has one of the longest half-lives of any of the drugs we use. It's 40 hours. So even if the patient forgets to take a dose, they're really okay with chlorothiazide. So that's the main reason probably why thiazides are so much more effective than Lasix. We have to use loop diuretics when the GFR is low. In practice, below about 30 mils per minute, or CKD4, let's say. But otherwise, your choice for hypertension should normally be a thiazide first. And by the way, spironolactone and eplerenone that block the aldosterone receptor are also good at lowering blood pressure, and they have even less natriuretic effect than a thiazide, but very long duration.
Okay, so...
Okay. Ingestion of drugs or substances, we'll come back to that. Inappropriate treatment regimes, you sometimes see patients who are on an acimimab together, and we now know that that's really counterproductive because there are more adverse effects, particularly on the kidney, and little benefit for blood pressure. Inability or disinclination to comply, we've mentioned, and secondary causes are important, and we'll come to that, so that if a patient has drug-resistant hypertension, there's always an invitation to work them up for either cryptic other causes of hypertension. You might think of thyroid disease, which doesn't always come to mind, accounts for a few cases of hypertension. CKD and diabetes are probably already obvious, but also secondary hypertension, namely adrenal hypertension and renovascular hypertension, which we'll finish the talk discussing. Okay, we talked about white coat and the use of home blood pressure. Sometimes we don't really have, even so, a clear view of what the pattern of blood pressure is. So if you have such a patient, you can refer to us in nephrology, and we can do an ambulatory blood pressure monitor. I don't know if any of you have seen these things, but it's a cuff that fits around the arm. It goes to a thing where, like a pager, the patient can put in their pocket on their belt, programmed, and it goes off every 10 minutes during the day, every 20 minutes at night, and records the blood pressure very nicely. Probably the most accurate way we have of assessing blood pressure. Not strictly necessary in all patients, but here you'll see a patient who has high blood pressure during the day, but normal blood pressure at night. And so they have a preserved nocturnal dip. If you look at the records of ambulatory blood pressure monitor and relate them to cardiovascular events, the overall level of blood pressure is important for sure, but the failure to dip at night is an additional risk factor. So could I ask you, why does your blood pressure normally fall at night, do you think?
Probably less sympathetic tone.
Good, and more vagal tone, absolutely correct. So what this is really telling you is the sustained sympathetic activity during the day and the night time. And there's nothing the heart fears more, as it were, than sustained sympathetic activity. So that's perhaps the link between failure to dip and increased cardiovascular risk. So you can only really diagnose that at the moment with an ABPM, and if you've got a hypertension referral clinic like I run, we do quite a lot of them because patients come because they really want a proper assessment, but it's not probably necessary in usual practice.
Do you ever recommend giving blood pressure medications at night instead of the morning, and would you only do that after?
It's a great question, and it's called chronotherapy. And it's a very controversial area because there are now, I think, 8 studies in the literature, all from a single center in southern Spain, and which is not an academic center, I might say. They don't publish anything except on this. And they've shown with each of the drugs that if you give it at night, you get a fall in blood pressure. Not only that, you then get a reduction in cardiovascular events, a reduction in progression of CKD, and a reduction in stroke. Very strong. But in the few trials where people have tried to reproduce that in other centers, hasn't been effective. And indeed, it sort of was counterproductive because one of the drugs, for example, they gave at night was chlorthalidone. And from what we just said, it shouldn't make any difference whether you take that in the night, the morning, or even, 2 days. And yet they showed it lowered the blood pressure more and had better protection. So we just don't know. It's very frustrating. It's a good question. So here is a trial of patients who have had blood pressure in the clinic and ambulatory blood pressure measurements. You could probably got much the same information perhaps with home blood pressure, but here they did ABPMs. And as you'll see at the top, all the patients had very high clinic blood pressures, about 170 to 180 systolic. And then when they stratified them by the level of ambulatory blood pressure, shown here, there were some who was confirmed did indeed have hypertension, some who had sort of borderline, and some who had really normal blood pressure. And then they followed them up to see who had heart attacks and strokes, and the risk went with the ambulatory blood pressure, not with the clinic blood pressure, as you might expect. And as we said earlier on, that white coat hypertension, as such, doesn't really carry an increased risk. And here's an extreme group then who had blood pressures as high as 170 systolic in the clinic and as low as 130 by ABPM. And indeed, they did not have lots of risk. So we mentioned about the salt intake, and you got that right. Just a word about salt sensitivity. We could talk for easily the hour on that, but we won't because it's got too much else to cover. But one thing that predicts that the blood pressure is going to be very sensitive to salt is chronic kidney disease. So when the GFR gets below about 40, then the proportion of patients whose blood pressure goes up steeply with salt increases a lot. So as you have a patient with drug-resistant hypertension and CKD, it often goes together, salt intake becomes all the more important to consider. We discussed that. I'm going to skip a bit because I want to get to secondary hypertension. So I'll just say that a lot of drug-resistant hypertension is patients, is doctors who have been afraid, in a sense, to use enough diuretic. And part of that is the pharmaceutical industry, because the pharmaceutical industry makes no money out of diuretics, as they're all generic. And for a long time, they're making a lot of money out of ACEs and ARBs and calcium channel blockers, although they're mostly, as you know, off patent now. But during that period of time, the reps would come round and talk to you about the dangers of hypokalemia with too high doses of diuretics and how you should go quickly to an ACE or an ARB, etc. And that's sort of ingrained in people's mind now. So most people are reluctant to use more than 12.5 or 25 milligrams of hydrochlorothiazide, let's say. However, like in all things in medicine, if you have a big problem, it's not responding to your first-line treatment, you've got to use higher doses of your drugs to make sure it really comes. And so in this particular setting, you may need to use more than the usual dose of hydrochlorothiazide or chlorthalidone, and to combine it often with another diuretic. And a very nice combination is a thiazide diuretic with spironolactone or a Clarinone that block the aldosterone receptor, because they also block the hypokalemia and alkalosis that complicate thiazide therapy. So that is a nice thing to think of. And indeed, this pathway trial showed that in drug-resistant hypertension, if you added spironolactone or an alpha-beta blocker, carvedilol, or a beta blocker with extra activity like nebivolol, spironolactone was more effective. So that's really a good trick to think of. Incidentally, spironolactone, what are the main side effects of spironolactone, could I ask you?
Like, it says like gynecomastia.
Yes, really nasty side effects in males, not so bad in females. Some females get irregular menses, but not much more than that. But males, according to the dose, get not only gynecomastia, which we think of, and not only impotence, but loss of libido, too. I mean, it's a pretty miserable combination. And a Clarinone, that's because it's a drug that was introduced in 1965 based on the steroid structure of aldosterone, which is very close to testosterone. So it blocks the androgen receptor as well, off-target effect. A Clarinone doesn't do that, so it would have replaced spironolactone if it wasn't for the fact that it's a lot more expensive. So spironolactone is perfectly good for most women, a Clarinone for males, certainly if you've got to use high doses.
What is I don't think I understand, what's the pathophysiology behind the potentiation effect of the diuretics on the other medications, especially in those populations?
Oh, good. So we mentioned, what tends to happen if you take daily doses of any diuretic, you get loss of salt the first day, and less the second day, and none the third day. That's the so-called breaking phenomenon. And, you know, that's a safety valve, if you like, and may prevent you from over-treating patients. On the other hand, as you've seen and know often, there are many patients with heart failure who have resistant edema and congestion and keep coming back to hospital, despite high doses of loop diuretics usually. And what we found is that most of that the loop diuretic is still working to inhibit sodium reabsorption in loop of Henle, but it's concealed because downstream the nephron hypertrophies and can reabsorb a whole lot more salt. So normally the thiazide-sensitive segment is only reabsorbs about 3 to 5% of the sodium. But after a few days of furosemide, it becomes huge and can reabsorb 20% of the sodium. It becomes loop diuretic-like. So the same will happen with the ENaC, which is the target for aldosterone. So it's logical then to use diuretics in combination to block this compensatory reabsorption downstream.
And then that'll make the ACE and ARB and the beta blocker work better.
Yeah, well, an ACE and an ARB, so that's another thing really. So ACEs and ARBs not only tend to cause a rise in potassium and diuretics, mostly before, which is nice, but they often do retain some sodium, or putting it the other way around, diuretics activate the renin-angiotensin system, and part of the compensation to them is a rise in renin-angiotensin. And so if you block that with an ACE or an ARB, you get a beneficial effect. Good. So drugs that raise blood pressure, I think we should just consider the ones that pretty regularly raise it, which anabolic steroids. There are drugs like midodrine, which are sympathomimetic amines that you give deliberately to raise blood pressure. Cocaine, nicotine, and Avastin, which is an oncology drug, you've probably come across that, blocks angiogenesis. And then erythropoietin is a bit of a problem in nephrology. Non-steroidal agents and COX-2 blockers are just as bad. Clonidine withdrawal causes a rise in blood pressure. So we talked about this, so let's not go on too much about that. And so identifiable secondary causes. So let's get on to that a little bit. By the way, my watch isn't working well. How much longer do we have, roughly?
12:36 right now.
Okay, thank you. So will you tell me about 10 minutes before we do stop? Thanks. So the two commonest causes of secondary hypertension are renovascular hypertension and primary hyperaldosteronism. And I'm going to concentrate more on primary hyperaldo because it is very important for you to identify it because it's good treatment. Whereas renovascular is a little bit of a paradox at the moment. I spent a lot of my earlier career trying to improve ways to diagnose and treat it, but it turns out that by the time it's established, it's caused changes in the kidney which are not reversible. So it's rather a disappointing target. Other things such as pheochromocytoma I won't mention because they're very rare, whereas primary hyperaldo is surprisingly common. So you know how to screen for identifiable causes of hypertension. Diabetes, the best screening test is the hemoglobin A1C. Chronic kidney disease, creatinine, but always measure microalbumin in the urine. Renovascular is an ultrasound with a duplex Doppler of the renal arteries. We'll come to that in a minute. Sleep apnea, don't forget it. It's common, surprisingly common, and we often miss it. Carter Road. Thyroid disease, you know how to do that. Primary hyperaldosteronism, the best screening test is probably a serum aldosterone concentration factored by plasma inactivity. And I'll show you the data that has really suggested that. And the only thing I'm going to say about pheochromocytoma is that the best way to screen for it is plasma metanephrines. So primary hyperaldo, we define it as low renin hypertension with persistent aldosterone secretion despite high salt intake. And that, in a way, tells you then how we got to diagnose it. So normally, aldosterone or mineralocorticosteroids have three effects. They increase reabsorption of salt in the distal tubule, which expands the body fluids, inhibits renin secretion, so they lower plasma renin activity, and that's one of the hallmarks. The increase in plasma volume, together with some direct effects on the heart, increase the cardiac output, and that coexists with vasoconstriction and raises blood pressure. And the effects on the distal nephron to increase salt reabsorption and increase potassium secretion. So hypokalemia is another factor. We used to really think that you needed hypokalemia to consider primary hyperaldo as a diagnosis. And I'll show you some of the arguments for and against that in a minute. So normally a high salt intake suppresses aldosterone secretion, and that's one of the ways that we keep our blood pressure relatively independent of salt. But if you have ongoing aldosterone secretion from an adenoma or bilateral adrenal hyperplasia, then your blood pressure is highly salt sensitive because you've lost this nice regulatory pathway. So let's talk a little bit about primary hyperaldo. So this is, there are two forms. There's aldosterone-producing adenoma, or APA, and that is just like it says, a benign tumor of the aldosterone segment of the adrenal gland. And then there's bilateral adrenal hyperplasia, which is commoner, and they're both adrenal glands are overproducing aldosterone, which has lost the normal regulation by angiotensin and salt. It's very, very important to you. One of the actually trickiest diagnoses in some ways for internists is to separate these two. But it's a major mistake to send a patient for surgery to take an adrenal gland out if that's not the cause of the hypertension. So we'll talk a little bit about how to diagnose it and how to separate the two. But this shows you that most of the big studies that I gathered up till about 20 years ago, it's not really changed, have shown that the frequency of aldosterone-producing adenoma in a referral clinic is about 2 to 3%. So that's not that uncommon, really, if you think that this is truly a curable form of hypertension in a number of the patients. So it's well worth diagnosing. So on the other hand, if you make the diagnosis by an increase in aldosterone to renin ratio, a group in Japan about 40 years ago showed that this was this picked up a large number of patients. And it picked up the bilateral adrenal hyperplasia patients as well as the adenoma patients. And now you see that the frequency in these various different reports of primary hyperaldosteronism in a referral clinic is about 10 to 12%. That's pretty remarkable. So if you're working in a hypertension clinic, at least, you would expect to diagnose primary hyperaldosteronism in every 8th patient. And if you're in a general medicine clinic, it might be every 16th patient, let's say. But it's a significant group of patients who will benefit from this diagnosis. So what are the subtypes and the pathophysiology? I mentioned this idiopathic hyperaldosteronism and aldosterone-producing adenoma. And the main, really, this summarized, I don't think we have to go through it, but usually the aldosterone-producing adenoma produces more aldosterone, has more severe symptoms. Now, we used to feel that if you diagnosed primary hyperaldosteronism and did a CT and found a tumor on one side, then the next step was to send the patient to the surgeon, have that adrenal gland removed. But we now realize that that's not good practice for two reasons. One is that even in the normal population, there's a adrenal enlargement that can look like an adenoma in about 10% of the population. And if you've got bilateral adrenal hyperplasia, it's sort of nodular and may certainly look abnormal on a CT. And on the other side of the coin, about 1 in 5 patients with an adenoma, it's too small to see on CT, the macroadenoma. So basically, it's not really logical to do the CT at all. I think we mostly do, but you should be guided by other ways to make the diagnosis. So how would you make the diagnosis between somebody who's got high aldosterone levels, and you've got to know if it's coming from one adrenal gland or both?
I would categorize the vein.
Yeah. Right. Have you seen any patients with that? No, we don't do it very often, and just between those of us here, I don't send my patients to the radiologist here. Radiology here is very good, but it's very specialized, very difficult to find the adrenal veins. I send them to somebody at George Washington Hospital who has tremendous success, but it's very difficult to do. And there's no nuclear medicine test that's available for picking it up. It's the only way to do it. And we'll come back to that in a minute. So the pathophysiology is rather fascinating. Both the adenoma and the hyperplasia are examples of somatic gene mutations. In other words, if you take the tissue from the adrenal gland and you subject it to DNA analysis, you'll find abnormal genes, but they're not present in the genome of the patient. So that tells you it's not an inherited condition, but it's an acquired condition. And what causes it to causes this genetic abnormality, or if it's even just a random event, we really don't know at the moment. But basically, these are genes that lead to changes in the membrane potential on the intracellular calcium, and aldosterone synthase is calcium dependent. So that's the mechanism. So what are the best ways to screen for these conditions? And that's the adenoma and the hyperplasia. So let's just look at sensitivity, because that's the most important. You don't want to miss it, right? You want a sensitive test that's going to pick it up. And you see a low plasma renin activity, not very helpful. Rather surprisingly, plasma aldosterone also not very helpful. Okay? If you look at the plasma aldosterone to plasma renin ratio, it's a good deal better, and it's simple. It's what we tend to use. But with most endocrine diseases, if it's an overactive gland, the best way to diagnose is to do a 24-hour profile. And funnily enough, 24-hour aldosterone excretion, not very good. As you see, 71% sensitivity. Even free aldosterone, when you can get it done, is not very good. And the reason is that 80 to 90% of aldosterone that we generate is metabolized to tetrahydroaldosterone. And there's a lot of, it's one of these CYP enzymes, there's a lot of variability between individuals. So if you measure tetrahydroaldosterone, it's pretty sensitive, really very good. But here's the rub. We can't do it here. And I can't get the lab to do it. There are certain universities that offer it as a special service, but it's not available as a routine. But the bottom line for you then is that the best we have in practice is the serum aldosterone concentration divided by the plasma renin activity. So what about hypokalemia? And this slide was from a large number of patients, about 1,000. And overall, only 30% in red of the patients who had hyperaldosteronism had clear-cut hypokalemia. In other words, it's a terrible screening test. But what I think we tend to forget is the normal way to take blood is you send the patient down, they put on the tourniquet, and then they give you something, a little ball to squeeze, right? Squeeze, 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 squeeze. So what's happening? So when you squeeze, your muscles are contracting and releasing potassium into the extracellular fluid. And the tourniquet prevents it from washing back into the circulation, so it accumulates. And normally, if you do this systematically, you'll find that the serum potassium increases by about 0.6 millimoles per liter by this technique. You can do the tourniquet, but not the squeezing. So tell your patient, if you're interested in getting accurate potassium, to tell the phlebotomist not to do the squeezing, or just tell the patient politely just to pretend to squeeze. Sometimes and setting up a wall between the patient and the phlebotomist, because they always love the squeezing. I think it makes the veins stand out. So as you can see, if you draw the serum carefully, then hypokalemia is a very sensitive test, actually, of hyperaldosteronism. So we have really three profiles if you look at renin and aldosterone together. The one in the middle is what we're talking about, primary hyperaldo, where there's the renin is suppressed because the volume is expanded. The aldo tends to be high, but as we mentioned, not terribly consistently, but the ratios are more helpful. Then there's a group of patients that have high renin and high aldosterone, and that's secondary hyperaldosteronism, and they mostly have renovascular hypertension, high renin essential hypertension, diuretic use, for example, and malignant hypertension. And then there's a small group that have suppressed renin and aldo, and the most best example of that is Liddle syndrome. So I think, let's see, excuse me. Could you tell me what Liddle syndrome is? It's a bit tricky. Anybody know what it is? Yeah.
A deficiency of the transporter which mediates the excretion of potassium at the distal, at the collecting tubule.
Great.
So you get the picture of having deficiency of aldosterone or
Good.
that's the equivalent.
Yeah, you've got most of it there. Well done. So it's a familial condition of the epithelial sodium channel in the collecting duct.
William Day or Bill Welch.
Bill, can I'll call you back if I may.
Sure.
Bye. I should turn this off. So it's a familial condition, and the ENaC is rather a complicated channel. It's got 4 components, and they get stuck in the membrane. Normally, the ENaC circulates. It's retracted from the membrane, reprocessed, and put in again. Aldosterone pushes it into the membrane, so it makes ENaC more active. We reabsorb more sodium and secrete more potassium. But in Liddle syndrome, it's there all the time, inappropriate. And so this is a highly salt-sensitive form of hypertension. And because there's excessive retention of salt and water, expansion of the blood volume, renin and aldosterone are turned off, okay? So it's an important condition, but quite uncommon. So if you have a patient who you think may have primary hyperaldo, and because of spontaneous or evoked low potassium, we mentioned drug-resistant hypertension, but unfortunately about a third don't have any obvious factor. So it's a bit of a dilemma as to whether to spend the medical resources of measuring renin and aldo in all hypertensive patients. And I think here you use your clinical judgment. If the patient has a lot of other medical conditions, it's tremendously important to get really good control of the hypertension. Or if you suspect non-compliance, this kind of thing, and you've got a chance of finding a fixable cause of the hypertension, it's well worth looking. And then we do the serum aldosterone to plasma renin activity. But the diagnostic test is something that the patients think you're a crazy doctor when you tell them. You've been worrying them about salt intake for the last several years, let's say, and now you want to tell them, now you've got to tell them, you want them to take salt capsules for 3 days to get a very high salt intake. Because the diagnostic test is to get the salt intake up and to show that the aldosterone is still high, okay, non-suppressible. So at the end of the 3 days, you measure the aldosterone in the urine, and if the excretion rate is more than 8 to 12, it's non-suppressible hyperaldosteronism, and then you've got the diagnosis. So then you need to dissociate between the adenoma, because that's a surgical treated condition, and the bilateral hyperplasia where you use spironolactone or eplerenone. And this is results for the bilateral adrenal vein sampling. And in this study, out of 20 patients who were proven to have an adenoma, the ratio one side to the other was about 18:1, very obvious, and always more than 4:1. If they had bilateral adrenal hyperplasia, it was always less than 4:1. So 4:1 is a reasonable cutoff point. But in practice, refer them to my clinic if you don't mind, 'cause it's great fun. I enjoy doing this. And I do think it needs some interpretation. For example, if you send it to the radiologist here, you're very likely to get a call that evening because they're all very proud of themselves. It's very difficult to get both adrenal veins. They're tiny hair-like little things. Got both adrenal veins on your patient, excellent samples. And the trick is, what your trick is to make sure that they send it for cortisol as well as aldosterone. Because half the time, they're not in the adrenal vein. And so they get a lovely difference, and you think, they're very pleased with themselves, but the cortisol does not show the step up as you expect if you're in the adrenal vein, right? So always check. If the cortisols are high on both sides, it's a good sample. If one of them's low, it's useless. Okay, are we nearly finished?
4 minutes.
Yes.
4 minutes.
Yes.
Oh, okay. So let's just finish up. So this is the subtype evaluation. You confirm primary hyperaldosteronism with the salt blending test. You then do adrenal vein sampling and look for a greater than 4:1 ratio, providing you've got plenty of cortisol on both sides. If it's high, it's unilateral hyperaldosterone secretion, almost always an adenoma, and send the patient for laparoscopic adrenalectomy. And the results are very good. If it's moderate hypertension, most have cure of the hypertension, all have cure of hypokalemia. And LVH regression occurs in all of these patients over time, so it's well worth doing. Very severe hypertension doesn't always completely reverse. If it doesn't localize, then you treat pharmacologically with spironolactone or eplerenone.
What happens if we treat the left one with spironolactone?
It works pretty well, but you don't get such good suppression of LVH, etc. Probably because if you go high enough on the dose to really block the high levels of aldo that you have in this condition, you get a lot of gynecomastia and other nasty things. So you can use it if the patient's not a candidate, but now with laparoscopic surgery, most people are candidates. Yeah, it's a good question.